Welcome to The Explainer. Today we are diving deep into a really serious topic, spontaneous bacterial peritonitis, or SBP. This is a formidable infection of the abdominal lining, and it's a major threat, especially for patients who are already dealing with advanced liver disease.
So, what exactly is SBP? Well, at its core, it's an infection of the acidic fluid, that fluid that can build up in the abdomen. But here's the key. There's no obvious source inside, like a burst appendix or something. It's what we call a primary peritonitis, and for patients with liver cirrhosis, it is a massive complication that demands we act fast and get the diagnosis right.
Here's how we're going to break it down. We'll basically walk through this like a real clinical case. We'll start with the diagnosis and figuring out which pathogen we're up against, then move right into treatment for both adults and kids. After that, we'll zoom out and look at the bigger picture. Infection control, and of course, the really severe complications that make SBP so incredibly dangerous.
Okay, let's kick things off with diagnosis. I can't stress this enough. Success in treating SBP completely hinges on doing meticulous work in the lab. Think of it as a bit of detective work. We're unmasking the specific bug causing the trouble. And that's absolutely vital for choosing the right treatment.
This diagnostic pathway is our roadmap, and it's all designed to give us the best possible shot at finding the culprit. We inoculate the culture bottles right at the bedside because that dramatically improves the recovery rates. Then we let them incubate for at least 3 days, to give those slower-growing organisms a chance to pop up. And notice that last step? If nothing grows, our hunt isn't over. That's when we call in a medical microbiologist. It's a really systematic approach, and it lays the foundation for everything that follows.
So, once we get a positive culture, who are we actually looking for? Understanding the usual suspects is key because it helps us predict just how severe the infection might be and lets us tailor our treatment right from the get-go.
The pathogen profile here is, well, pretty lopsided. Gram-positive bacteria are the cause in a staggering 80% of these cases. And that single piece of information is hugely important. It directly shapes our initial or empirical antibiotic choices before we even know the exact species.
But look, not all pathogens are created equal. Far from it. An infection with something like Staphylococcus epidermidis might be less severe, something that could potentially be managed as an outpatient case. On the other hand, if we identify Staphylococcus aureus or any gram-negative rod, that's a huge red flag. That signals a much more severe infection, and that patient is getting hospitalized, period. And notice the fungi, while maybe not as severe right out of the gate, they can be unbelievably persistent and difficult to treat.
Now, for patients on peritoneal dialysis, the picture gets a little more complicated. Here, we tend to see a wider range of bugs, both gram-positives and gram-negatives. And this includes some really tough customers like Pseudomonas and Acinetobacter. It makes sense, right? The dialysis catheter itself creates a potential doorway for a whole different set of microbes to get in.
All right, so we know what we're up against. How do we actually treat it? This is where all that diagnostic work pays off, guiding us from that initial broad-spectrum guess to a very specific, targeted antibiotic regimen.
Our initial treatment plan depends entirely on what we think the source is. For primary SBP, the main focus here, the standard approach is a 1-2 punch of cefuroxime and gentamicin. But if we suspect a secondary cause, maybe a bowel perforation, we have to add metronidazole to the mix. And the reason for that is critical. We need to provide coverage for all those anaerobic bacteria that live in the gut and have now spilled into the peritoneum where they absolutely do not belong.
Okay, time to put this into practice. Here's a super classic case. A 68-year-old man with cirrhosis. He's got a fever, his acidic fluid is cloudy, and the lab calls you with the initial gram stain, gram-positive cocci arranged in clusters. So thinking back to what we just covered, what's your number one suspect and what drugs are you starting right now?
In a scenario like this, everything about the clinical presentation just screams SBP. And that gram stain result, gram-positive cocci in clusters, is a classic signpost pointing straight towards Staphylococcus aureus. But, and this is a big but, we can't get tunnel vision. In a patient this sick, we have to start broad-spectrum antibiotics immediately, ones that cover both the likely gram-positives and any potential gram-negatives until those final culture results are back.
And here's our answer. The most likely pathogen is, in fact, Staphylococcus aureus.
The immediate empirical therapy is exactly that combo we discussed, IV sufroxime and gentamicin. Then, once the lab confirms it's S. aureus and gives us susceptibilities, we can de-escalate to a more targeted 3-week course of intraperitoneal cefazolin.
Okay, after all that dense clinical talk, let's take a quick breather. I've got a terrible microbiology joke for you. Why did the bacterium break up with the other bacteria? Because it felt too much pressure from the antibiotic treatment.
All right, moving on. Let's switch gears to a pediatric case, which brings a whole new set of challenges. We have a premature neonate who's starting to show signs of sepsis. The lab calls with a blood culture gram stain, but this time they see gram-negative rods. How does that one single finding completely flip our treatment plan on its head?
So, while we often start neonates on ampicillin and gentamicin for suspected sepsis, the second we see gram-negative rods on that stain, we have to pivot immediately. We escalate to a really powerful broad-spectrum antibiotic like meropenem. The reason is simple and stark. Gram-negative infections in these tiny patients can be absolutely devastating, so we have to hit them hard and fast while we wait for the final susceptibility results.
You know, treating the immediate infection is just one part of the job. Next, we have to think about infection control and prevention. This is about protecting the patient from it happening again, but it's also about our broader duties to public health.
And that brings us to a really crucial point about public health. Now, the bugs on this slide, like the ones that cause botulism or diphtheria, aren't typical SBP culprits, but they illustrate a vital principle. Certain invasive infections, like those from Streptococcus pyogenes, which can cause peritonitis, have to be reported. This is a mandatory public health duty. This kind of surveillance is what helps us track potential outbreaks and protect the whole community.
Going back to our peritoneal dialysis patients, managing that catheter is everything. If you've started the right antibiotics, but that dialysis fluid isn't clearing up by day 5, that catheter has to come out. It's almost certainly the source of a persistent biofilm infection, and you'll never get a cure until it's gone.
Now we need to talk about a more somber topic: the really grave consequences that can happen when SBP isn't controlled. These infections don't just stay put in the abdomen. They can spiral out of control and cause devastating systemic problems.
The true danger of a pathogen like S. aureus is its ability to spread through the bloodstream. Once it causes bacteremia, it can set up shop anywhere. It can lead to endocarditis in the heart valves, osteomyelitis in the bones, even abscesses in the spine. It can trigger this horrific cascade that ultimately leads to total systemic collapse.
And this is the final common pathway. Uncontrolled infection leads to septic shock. That's when the body's own overwhelming response to the infection starts to attack its own tissues and organs. This leads to widespread, multi-organ failure. It is a dire medical emergency with an extremely high mortality rate.
Just look at the potential for severe long-term damage. Peritonitis from certain S. aureus strains can lead to necrotizing pneumonia. If the infection spreads to the brain, it can cause permanent neurological damage from meningitis. And in certain patient groups, like those without a spleen, any bacteremia can trigger a catastrophic, overwhelming infection. This is exactly why we must always treat peritonitis as a life-threatening medical emergency.
So, I want to leave you with a final thought, a question looking to the future. We've outlined the protocols we use today, all based on the best evidence we have. But bacteria are evolving targets. With the relentless rise of antimicrobial resistance, the real challenge facing all of us is this: how do we make sure these complex strategies adapt and evolve so we can stay one step ahead of a constantly changing enemy? Thank you for joining this explainer.